Today we'll be talking about the fifth pillar, prioritization, the triage and delegation. And you guys already know about my prioritization technique. And so we have a B. B basically talking about anything that affects breathing. But as you can see, we have a P, pulmonary embolism. And that is a breathing problem. You have to identify it. It may be somebody who had a DVT. I need to be sharp about it. Being sharp means you're looking at a patient twice. You said, I have to look at a patient twice and make sure I'm not missing anything. So the patient can have a fusion that can put them in tension, cardiac tamponade, pulmonary edema. And they won't tell you it's a pulmonary edema, but they will describe it somebody with the CHF as a pink fluid sputum. All pink fluid sputum, when he coughs, there's blood in it. It means their lung is congested. The lung is drowning in the fluid. And then basically the blood vessels break down. And then when they cough, there's blood in it. So these are the bad ways you hear them. You said, I'm dealing with a breathing problem and I need to be sharp about this patient so that I don't cause morbidity to that patient. Okay. So the next one is talk about electrolyte. There's key electrolytes, sodium, magnesium, calcium, and potassium. These are what control homeostasis of your body system. And whenever there's a decrease, either decrease or increase in their level, it changes your body function. So you got to pay attention. You can see potassium, usually cardiac effect. Calcium also has cardiac effect. Magnesium also both cardiac and muscular effect. And sodium is neurological. And so those things you have to start thinking. When you see them increase or decrease, you have to evaluate your option choices and say, do I let this go? Or do I need to say something to the doctor or do something about it? Okay, the S is two forms. You have sepsis and shock. So sepsis means they have temperature. Usually those are the triage of sepsis. So you have temperature, it will be increased. So temperature, so this patient have temperature and they may have fever, so they have hypotension. Remember the temperature can be low or high temperature. So low or high temperatures. So a low temperature, you can have a temperature of 96. That is not good in a septic patient. And they may have changed in mental status. Okay, those are the things you're looking for. Or they have a wound that look infectious. Okay, patient has a wound with white count increase, yes. And the sepsis, the S shock, basically heart rate goes up or blood pressure goes down. And then they have changed in mental status. That's what you're looking for. So they will give you those things, but they won't tell you the patient is in shock. You have to put the numbers together and decide what it is. And the H talks about hypothermia. Like I told you, a patient who is hypothermic is a cardiac problem. I'm talking about like 96, temperature of 96, 95. You should start thinking, this is not normal. I need to do something about it. And hypoglycemia. So sugar, they will give you sugar 300, 500. I don't care about sugar. That is mostly hypoglycemia is the most because it affects your neurological function. Okay, neurological function. So like sugar, finger stick less than 60. Okay, then you start worrying about it. You don't have air, you cannot breathe. So number one, you can't function. So airway. And the airway is full of bad ways. So restlessness. Okay. Patient will be drooling. Okay. That's not good. They will be grunting. That's not good. Okay. They will have a stridor. That's not good. Those are bad ways when you hear it in the who do you see or patient, they're describing a patient in the statement and you see those things, your antenna should be going up and thinking about, I need to see this patient again. Okay, acute confusion, okay, can also come here. All of a sudden they confuse, they may be hypoxic. So confusion sometimes represents hypoxia, depending on the condition. Okay, so, and that is number one, it's our style. So you got to be careful when you see that. They can give you multiple choices, but when you see A as an airway problem, then you have to take it. And the R is like neurological stuff, so neuro stuff. Okay, so a patient who had a seizure right away, you got to control their airway and then check their neurological status so that because they can't protect their airway because of the seizure that they have. So these patients are very important. They may be lethargic. And the reason why they are dying is because the brain is not functioning well. Okay. And then your breathing system is in your brain. So if your brain doesn't function well, you can't breathe, you can't protect your airway, your gag reflex will be affected, and that's a problem for this patient. And this is acute mental status change. Confusion also come here. Patient will be confused. Okay. So these are like a bunch of buzzwords I put together just to put you in a focused state. And then the last one is P. It's my favorite because it's very confusing. Every patient that comes in will have a pain, some form of pain, like 95% of them. But not every pain is important, okay? You're looking for pain that will affect their life, okay, and their limb. So life, limb, and eyesight. So if you think this pain is they're going to lose their leg, they're going to lose an organ, they're going to lose something, then you got to do something about it. If this pain, they're going to lose their eyes if you don't do anything about it, yeah. If you have migraine headache and you have pain in my eyes, migraine headache never caused any problem with my eyes that will make me lose my eyes. But if I have glaucoma, acute onset, well, if you don't do something about it, I'm losing my eyes. That pain is more important than a migraine headache. And the life, okay, if you don't do anything, they die. Like somebody with the chest pain, from cardiac chest pain, you got to do something about it, otherwise they die. Somebody with the PE with chest pain, if you don't do anything, their airway, they lose their airway, they die. So life, limb, eyesight, they like to trick you. They'll give you a post-op patient with severe pain. Well, then another patient who has pain that they're going to lose their life, I'll choose that patient more than that. So in summary, be sharp, not expected, is a tool, okay? Toolbox, okay, made up of multiple, find a tool that will help you fix a problem. So we'll go with the disaster and triage. So basically triage scenario. This, many books make it difficult. And then I try to, in your head, you have to make it, compartmentalize it and make it simple for yourself. They're not going to ask you about anything than the person who is a priority. So the disaster triage scenario is different from trauma. Trauma, you got to like take care of one patient until the patient is better. In a triage, we're looking for good for a lot of people. So based on that idea, I want to save a lot of people. If you are going to die, unfortunately, and excuse me to say that, the doctor will let you go there. Save a lot of people. So save a lot of people with that resources you have. It's different from regular trauma. And then they have colors. They have like red, okay, they have yellow, green, and black, okay. And each of them, they label them. The red is basically is emergent, okay. So red is emergent, and the yellow is urgent, basically. It's non-urgent. With the black is expectant. That means they're going to die. For the exams, okay, you shouldn't worry about the yellow and the green because they're going to ask you about who do you prioritize. So I want you to focus on two things. Red patient. Just learn how to identify a red patient. Don't worry about yellow. Don't worry about green. If you are in nursing school still, yeah, you need to do yellow and green in your exams. But for the boards, care about red. And the red, there's only 4 things I'll tell you. Patient is in shock. It's red. Okay, that means their blood pressure is low, but you will not even have the chance to measure their blood pressure. They won't give you that because you are in the scene of the trauma. So you basically observing the patient that is in shock. You see a lot of blood. There will be a little bit of pale in color, skin changes. Yeah, you know they've lost blood. So shock, they have acute change in mental status, and you see blood all over their body. Yeah, that's a sign of shock. So you won't have blood pressure unless they give you blood pressure, but you won't have that. Okay. And then airway. You're just looking and see if there's airway. You check for strident. You can hear it. You can see chest movement, paradoxical chest movement. You see a sucking chest wound. All these things. You see them. You lift their head up. They're not breathing, and you listen. Yeah, observation. That's the airway problem. And then chest trauma. Anybody that had injury to the chest, no matter what, stab wound, rib fracture, anything wound that is open on the chest become a priority because the chest trauma will affect your airway and bleeding. That's the reason why. Chest trauma is an airway problem, a breathing problem, and even a circulation. So ABC there. Okay, that's why every chest trauma become a priority. And then if they have a wound that is unstable, okay, the wound that is not unstable, like if you have amputation, okay, that's a sign of hemorrhage, to lose their limb. So that patient, you can just immobilize explain the fracture quickly and allow blood to supply. Or they have amputation, or they have a wound that is bleeding, is unstable. These are the four: shock, airway, chest trauma, unstable wound. The black, which is expectant. Expectant, that's all you need to worry about. Patient has no pulse. So no breathing, no response, unresponsive, and no pulse. You check their pulse, they have no pulse. You shake them, they're not responding. I'm not going to do anything about it. If they have severe brain injury, so you can see actual penetrating wound to the head, okay? Head injury, you can see that like a brain matter is exposed, okay? Brain matter is exposed. Yeah, that's the problem. That's a severe. There are people, okay? That's how you can assess quickly neurological function. It's fixed and dilated. Yeah, that patient, no. If the patient has no airway, is not breathing, okay, you lift their head up, you do you move your jaw, you try to open, and there's the apneic. Is an expected patient. Don't waste your time. So you're giving 4 answer choices. You just go down and say, I'm looking for shock, airway trauma, and chest trauma and unstable wound. Shock, airway trauma, chest, unstable wound. Then I'm also looking for somebody who's an expectant. In between them, they are not a priority because then they confuse you more. The yellow and the green confuse you to get the red. So in order to get rid of the confusion, focus on the red and the black. So if I know you dead, I don't worry about it. And if I'm looking for these key factors: shock, airway, chest trauma, and wound unstable, then yes, those are my people. We have RN, and then we have LPN, and you can get a UAP, right? So there's things that you do. You got to delegate staff, okay? You delegate staff to them. There's few things you already guys know. I don't that the five delegation tasks, okay? So you got to make sure the person is the right person, okay? Right task, okay? The task has to be right. What does that mean? The individual scope of practice. They have to have scope of practice. So you guys are all taking these exams so that you can have a scope of practice defined by your training, okay? And so the person you're going to assign this, you have a scope of practice. The thing you assigning should have a predictable outcome. Outcome has to be predictable, okay? And then the risks associated with it is all minimum. So minimum risks. This is all it means, right tax. Okay, so you make sure whoever you're giving it to, he has the scope of practice, the outcome, you can predict it, and it's minimum. Okay, so that's the That's the way to assign for the task. Then circumstances. The circumstances has to be great. Okay, it has to be perfect. Not in the middle of trauma, you're giving something to a UAP that's never done it before. So, and it has to be a stable patient. So, not a sick patient, a stable patient, and in the right situation. Okay, circumstances matter. And the person, and I call it the KSA, knowledge, skill, and assessment. Okay, they have the ability, knowledge, skill, and ability. Okay, just because you are a nurse doesn't mean you can do certain things that you don't have been taught how to do it. Okay, you have to have the knowledge, skill. That's why when you get assigned to a ward, you undergo training for like 6 months. Somebody will precept you. That is what they're trying to improve: knowledge, skill, and assessment. You get a license as a nurse, but you may not know how to titrate a PCA. That's where you learn the knowledge, skill, and assessment. And so we delegate to somebody who have the skills, but it may be within their scope of practice. So they may have the right person. He's a nurse, so he's in the scope of practice to give a PCA, but it doesn't have the knowledge and the skill to do that because he has not done one on a patient before, or you have done it, but he's not confident. So you have to find the right person who is able to do that's knowledge, skill, and assessment. And then you got to give the right direction or communication where you tell them if there's any problem, you give them clear instruction. Okay, about if you see this, call me. Okay, if this and this and this happen, call me. Don't wait. And supervision. Supervision is the most important. The intervention, that's what your test is about. Supervision and intervention. And what does that mean? It's a spot learning. I call it spot learning. The UAP did something and you intervene right away. The LPN did something, you intervene. You don't wait 10 hours later. Intervene and you teach them. It's called a teaching moment. Okay? So that is the tax portion of it. Then you have to know what each of your components. So this is a team. RN, LPN, and the UAP, they all are in the team. Okay, so who does what? The RN is responsible. Let me use blue. RN is responsible to eat. Okay, that means they're going to do the education, all education, initial education, all assessment, and all teaching has to be done by the RN. Okay, they are responsible for all these jobs. Okay, and then what does the LPN does? I call it MMR most. That's the way I remember it. So M is the monitor. Okay, they monitor your findings. Okay, that's all they do. They can monitor your findings, and then they can give most medications. Okay, they give out most medication. So except IV medication or high maintenance medication. So high maintenance, like heparin drip or those using high maintenance. So or high risk medication, yeah, or advanced medication, like they call it, or IV medication, whatever you want to call it. By high risk medication, IV medication, they can't do that. And the R is basically reinforcement of your teaching. They tell the patient after you've taught them as the RN, they reinforce it. Then the M is basically repeating whatever is there. You can use monitor and most medication, which we already talked about it. But then the O is they can also do ostomy care. That's the tricky one. They can take care of ostomy. Ostomy means that's another problem. Let me give you guys gastrostomy. Ostomy means a hole on the skin from portion of the bowel. So gastrostomy, ileostomy, and colostomy, they are what classify as ostomy. So all of them is the same. And the S, they can do some specialized tests, like they'll listen to the lung, okay, listen to the lung. So you can do breath sounds, they can do bowel sounds, and then they can do neurovascular check. And the T is 2 feet. If they can do ostomy care, gastrostomy, then they should be able to give 2 feet. So that's the function of the LPN. Then the way I do the UAP is simple. I try to make it simple. UAP. Anything that does not involve thinking. Thinking means they don't have to analyze it. Okay, they don't have to analyze it and use any assessment. I would use the word assessment. There's no assessment. You ask them to take a virus, they will take it. They don't need to do any assessment. They check their vitals and they're done. Go measure the urine output. They take it and they go and measure and give it a value. Watch a patient eat. They stay there, watch the patient eat. Take the patient, raise the bed up. They do it. So it doesn't require anything like that. So, or you can say none of this, then UAP has to do it. That's all. So that's what they do, basically. So that's the way to make this easy as much as possible. When you assign, sometimes there's a specialized assignment, okay? Room assignment in terms of infectious disease. Okay, say room assignment. 2 words for you. If it's an infectious problem or prevent infection, let me say it that way. Prevent infection as much as possible. So don't put any 2 patients that one will infect the other. So if one is going to infect the other one, yes, no. And the people they will give you is a post-op patient. So patient just had surgery. Make sure if they're sharing a room, nobody is going to affect them. Or immunocompromised. People are getting chemotherapy or radiation, or they're on medication. And they're on medication that will make them sick. They make it a chemotherapy or radiation therapy, or they're on like UC patient on immunomodulators. You cannot put them in somebody who can infect them. So post-op patient, immunocompromised patient, don't put them together on somebody that will infect them. Then the second reason, okay, if they have the same infection, okay, you're dealing with organism, not precaution. Let me explain. This is key. This is how they trick you with delegation question. It's straightforward. I can have C. diff, okay, right? And somebody will have MRSA. Both of them is what? Contact. What is the difference? Organism. So you cannot put, even though they have same precaution, we are not basing on our this thing on that. We based on organism. Organism has to be what? Same C. diff or same MRSA. That's all. You can't have 2 precaution, but organism is different. Right? You can do that. So that is the key aspect of it. So you try not to do that as much as possible. So you can have 2 C. diffs or 2 MRSA. They have to be the same organism, but not precaution. And that is the way you should think about it. These are the 2 words for room assignment. If you know it, that's straightforward. Don't listen to anything. Just, I'm worried about not affecting a post-op patient or somebody who's immunocompromised. So I'm not putting anybody who is infectious with them. Secondly, if they both of them are infectious, I'm just looking for same organism, not the same precaution. You can have two contact precautions, they can be together unless it's the same organism. It can be airborne, they can be together unless it's the same organism. And that is what you do. The other thing too is floating nurse. They can give you a floating nurse. Okay. What is the principle? All this thing has a principle. Non-specialized patient. So if they are OB nurse and they come to med-surg unit, okay, you cannot give them specialized patient. You can give them patient that has routine nurse care. So somebody have appendicitis. So appendicitis, he's going home. And then OB nurse come in. You cannot give that patient to the OB, even though patient is basically is non-acute. You can't do that because she doesn't know any specialized teaching about appendicitis. Patient is going home. You need somebody who can educate the patient about what they look for post-op precaution so that they don't get sepsis. But if the patient, all they need is pain medication, well, fine. Pain med or routine nursing care, you can give it to them. And that is the principle of assignment, a floating nurse. So you can use that principle. I'm not going to give them, so discharge some like initial evaluation. All they need is, it has to be a nursing, routine nursing care, and those are the patient you just give it to. So let's do some questions. Let's do some questions. That's my favorite. So these are priority questions. So like I answer questions, you always read the last portion of it. Which of the following is a priority teaching at discharge? Okay, I have to teach somebody. Teaching, okay. A client was prescribed bumetanide. So that's my situation after a new diagnosis of heart failure. Which one is a priority teaching? So the way I answer questions, if that's SATA or anything like that, first answer these kind of questions. Read the last statement of the question, and then that will provide you with the asked. So the asked, that will provide you with the asked, which is a priority function. And the case is you read the rest of it. Bumetanide prescribed with the patient, new diagnosis of heart failure, which of the following is at discharge? And then the buzzwords is this medication, bumetanide, heart failure, and the rewrite is basically patient is going on with that. Okay, what is the priority teaching? And then you evaluate the answer. Slowly get out of bed. So when you rewrite, you come up with the things. What is bumetanide? Before even you look at the answer choice, look at it. Is a loop diuretic. What are the side effects of the loop diuretic? Basically, they cause hypotension, orthostatic hypotension, hypokalemia. Okay. So they are sulfur drug. So you got to teach them photosensitivity. And those are the main, and it causes other like they increase your uric acid. So those are the main things you have to know about it. Hypotension, hypokalemia, sulfur drug, and uric acid. And sometimes they increase your creatinine level a little bit. Okay, so slowly, get out of bed slowly. Okay, fine, it causes hypertension. Okay, does this really the biggest risk factor here based on what you've seen? Priority function. Look at the B sharp. Hypertension alone is not enough. The patient has to be in shock. There's nothing here that tells me. Slowly getting out of bed is giving you a clue that orthostatic hypertension. You have to be sharp about it. That doesn't not going to cause any problem with the patient. They may feel dizzy a little bit, but you have to teach them. So orthostatic hypertension is not a priority function. Wear a long sleeve when hot. Is it part of the B sharp? No. But you got to tell them to avoid photosensitivity to wear it, but it's not a priority function. eat some banana daily. Yeah, hypokalemia is electrolyte imbalance that can affect their cardiac function. This loop diuretic can do that. So the priority problem is hypokalemia. Avoid red meat. How does that relate to this? Red meat causes gout. Why? Because this patient will have high uric acid. But is this being sharp? You give them pain, but that's not the problem. The most important thing is hypokalemia, which is more serious than any of these side effects that loop diuretics like bumetanide will cause. So I'm choosing number 3. That's my answer. Same thing. We read the last statement. Which of the following is a priority nurse action? Okay, so that's our asked. Then which is our case? A client was diagnosed with viral meningitis due to headache, nausea, and vomit. A lumbar puncture was performed. Which of the following is a priority function? So our ask is looking for a priority function. Our case is somebody who have meningitis and they did a lumbar puncture. And what is our buzzwords? The same thing, meningitis and lumbar puncture, okay? And then rewrite, somebody who had meningitis, I did lumbar puncture, what is my priority function? And then you take this, after you rewrite and you look at your idea, okay, what you have to answer something in your head first before you look at the answer. What should I worry about? Lumbar puncture, they get hypotensive, so they get headache after it, and therefore, in order to prevent the headache, they've lost some fluid from CSF leak. So you give them fluid, you let them lay flat. If they still having headache, you do a blood patch. That is the management. Therefore, high follow position, negative. Assess for Kennen sign. Be sharp, okay? You already had the assessment, you already done what you think. Is looking for Kennen sign, which is the diagnosis of irritation of the brain, telling you they have meningitis important? No. The question is asking you, priority nurse action after the procedure. It's not asking you for the diagnosis of meningitis. I know they're going to have Kennen sign. I don't care about that. All I care about is lumbar puncture now. So assessing for this doesn't give me anything. Assess for deep tender reflex. Well, lumbar puncture, I don't need to do that. So a negative. So oral fluid intake is good. You give them oral fluid or you give them IV fluid. And if they still having headache, you give them, we do a blood patch. Basically, that stops the leakage of the cerebrospinal fluid. And that's the management of that. Okay. Same thing. This one, I put it in the SATA form, but it's the same thing as prioritization. That means more than one patient will be selected. So you have to like select more than one. And one of them, more than one will be priority. So who do you see first? The same thing. We read it, assess it, and see if it makes sense. We have to be sharp about it. A client with left-sided pneumothorax. Okay, you have pneumothorax, fine. Tidling chest tube. What is wrong with it? You have chest tube, you have 3 chambers. Okay, this is the suction chamber, this is the water cell, and then this is the collection chamber to the patient. Okay, if I have chest tube and I have tidling, it's good. Tidling is good. I want to see tidling. Tidling tell me the tube is patent and the patient is breathing. So my breathing is good. You see where they give you breathing thing and they don't tell you tidling is a good thing. That means I'm good. I don't see this patient first. A client with right shoulder pain after cholecystectomy. Ask yourself, if this is the patient, gallbladder is on the right upper quadrant. After they remove the gallbladder, that's cholecystectomy, they're going to have pain on the right because of the gas. It's referred pain to the right upper shoulder. So therefore, this is unexpected. I got to be sharp. A client with shortness of breath 2 days after pelvic surgery. You say, okay, you hear shortness of breath 2 days after pelvic surgery. Tell yourself, pelvic surgery, there's trauma there. Why do I have to worry about it? Shortness of breath, pelvic surgery. Anybody who have surgery, they're likely to get DVT, especially pelvic surgery. If they have shortness of breath, that's not good. They have PE. If you have PE, you have what? Airway breathing issue. And therefore, this is a priority. I need to see them. This patient has a PE, pulmonary embolism. A client with dry mouth and takes ipratropine for asthma. Okay, dry mouth, ipratropine. Connect the words together. Asthma patient on ipratropine. What is that? It's anticholinergic. What does anticholinergic do? Decrease secretion everywhere. So your bowel will go down. So constipation, okay, urine output retention, worsen your glaucoma and dry mouth. So this one, I'm not worried. A client in semi-fowler position 1 hour after kidney biopsy. Then your attendance should go up. Kidney biopsy, fowler position. Why are they connecting this thing to me? And they give me an hour. Pay attention. 1 hour, kidney biopsy. So those are my keywords. 1 hour, kidney biopsy, and semi-fowler. Kidney and liver are really vascular organs. If you stick a needle in the vessel, it will bleed. Because of that, when they have biopsy, you need to put pressure on the side. Unfortunately, they are retroperitoneal organ, especially the kidney. Since you can't put pressure on the kidney, when they have kidney biopsy, you let them lay on their back because the kidney is on your back, retroperitoneum. So when you lay on your back, you actually putting pressure on the kidney. So this one is red flag. It's a B-sharp moment. How? Liver biopsy is a bleeding organ. They're going to bleed, and I have shock. Shock is a B-sharp. So this I need to see. So that's what we have. Okay. Same thing, similar question. Who do you see in a SATA form? That means more than one. A client with left femoral angioplasty with swelling and perineal ecchymosis. Okay, this is the patient. You got to break down the word. Left femoral angioplasty means they did a catheterization. They go into the artery and they open the artery up, they remove their sheet, and there's no incision. When somebody have vascularization, like cardiac catheterization or angioplasty, your number one precaution is bleeding. Look for the groin. So this groin has bruising and ecchymosis. That means patient is bleeding. If they have back pain, bleeding. If they have perineal ecchymosis, bleeding. If they have curling sign, that means ecchymosis around the belly button, bleeding. If they have flank ecchymosis, that's bleeding. So those are the key words for them. So this patient is bleeding. And what is bleeding? Shock. So B-sharp moment right here. A client with myasthenia gravis and dysarthria. What is myasthenia gravis? It's a neurological problem, lack of acetylcholine because of antibodies to the acetylcholine receptors. What is their problem? If there's no acetylcholine binding, the muscles get weak. And their main problem is swallowing, airway issue. They can have weakness of their body. I don't care about it. I always care about the muscles of the neck. When the muscles of the neck started getting tired, that's what you want to work. Otherwise, it become an airway, a B-sharp moment. So if they tell me this patient has incontinence, it's fine. But so far as they're talking about dysarthria, yes, I'm taking him. It's airway. This is how they can put the airway, but they don't tell you. but you have to connect the symptoms and the diagnosis. A client with ALS complaining of fatigue and bladder incontinence. The same thing, one of those neurological problems that they have ascending neurological deficits. And the number one, these problems, ALS, AMS, okay, all these things, I only worry about them if they have airway problem. All their muscles will be paralyzed in the future, but until the muscles are not being affected, any symptoms they give you is okay. Therefore, this patient, I'm not worried about it. A client on digoxin taking local rice for depression, badness, bad. This causes hypokalemia. What are the problems with digoxin? Things you need to avoid is hypokalemia, avoid hypokalemia, hypomagnesium, and high calcium. So low potassium, low magnesium, high calcium. This will make digoxin toxic. Therefore, this, I'm seeing that patient, it's not good. A client with SIDH and a serum of 130. You see, we have a B-sharp moment, 2 B-sharp moment. This is a B-sharp moment. Digoxin, leucoryl rice, basically is hypokalemia, is a B-sharp, electrolyte, not good. SIDH with sodium of 130 is a B-sharp moment. That's the E portion electrolyte. Hyponatremia will lead to seizure. Therefore, we need to see this patient. Not good. Who do you see first? Multiple of them, so that you guys can get used to it. A client with acute pancreatitis and a serum of 200. Patient whose pancreas is affected, the pancreas doesn't function anymore. Pancreatitis, the pancreas can't secrete their insulin, so the glucose is going to be high. I know this is abnormal. Don't look at it. It's not one of the B-sharp. The B-sharp, you have hypoglycemia. I never put hyperglycemia, glucose 60 and below, because of its neurological effect. 200, no, you shouldn't worry. I know it look big, normal. Your brain cells will be telling you 200, why? No, stay focused, be sharp and not expected. So this go away. A client with bronchitis and a temperature of 101.5. Sorry, this is 101.5. What is the problem? Nothing. He has bronchitis. They have secretions. Then they can have infection. So this is a B-sharp moment, right? So we have a sepsis there, right? This is where it's getting hot now. So you have bronchitis patient, fever 101, yeah, sepsis. Okay, so I have S, B-sharp moment. I got to keep it. It's not my priority now. I can't eliminate it. So that's my priority. A client with pancreatitis and periumbilical ecchymosis. So he has pancreatitis and then he have ecchymosis here. Remember I told you about somebody having cardiac catheterization or the angioplasty with ecchymosis is the same thing. Pancreatitis can lead to retroperitoneal hemorrhage because there's vessels around the pancreas and the inflammation will let them cause the injury. And therefore you have all this ecchymosis. Ecchymosis for pancreatitis, this is a B. So now we have a B. And so bleeding and sepsis, which one is more dangerous? I choose my B. So breathing is shock. So breathing and you have shock. Bleeding and shock. So I'm choosing bleeding. Okay, so that's a bleeding problem. Bleeding problem. I'm choosing shock. Then the last one, a client with asthma exacerbation and no wheezing. This one, problem. An asthma patient should never stop wheezing. Even if you treat them, before they come in, they're wheezing. when you treat them, they will continue to wheeze. If they stop wheezing, something wrong. Asthma patient will never stop wheezing. Therefore, any asthma patient who come in with asthma exacerbation, stop wheezing is a problem. So I have a bleeding problem and then I have an airway obstruction. I'm choosing that. So we have A, B, C. We have airway here. We have sepsis, and we have a bleeding shock. So I don't like the ABC thing. That's why I don't use circulation now. I always use the diagnosis. So I have an airway obstruction, I have a shock, and I have a sepsis. Which one will you want to choose? If you don't have oxygen in your system, you're dying. So I'm choosing my number 4. It's more important. If I don't take care of this patient, he dies. Shock, I have some chance to give them fluid. Sepsis, I'll give them antibiotic and take care of it. But if I'm comparing these big guns, I'm taking asthma patient over that. Same thing. Same thing. SATA multiple. A client with acute pancreatitis and mid-epigastric pain. Well, that's where you're supposed to have a pain there. I got to be sharp. That's not important. A client with appendicitis, I intentionally said this, they all have pain, and you see what I'm trying to show. Appendicitis and right lower quadrant pain. Whenever they tell you the location, look at the organ that is over there. Pancreatitis is in the middle. You get pain if you have inflammation there. Appendicitis is on the right lower quadrant. You get pain if you have inflammation there. So this is expected. I have to be sharp. A client on trazodone and a painful erection. So he has trazodone and is erected for more than 4 hours. This is one of the side effects of trazodone, priapism. But it's been more than 4 hours. This pain is not just a single pain. It's the pain that will let him lose his limb. His limb is his penis. Okay, you don't want him to lose his penis. So you have to do something about it. This is a patient you will see. Okay, after 2 hours, it's dangerous. There will be necrosis. The pain is an ischemic pain, and that will make him lose his limb. That is it. He won't be happy about it. So that one is gone. A client with pericarditis with pain in inspiration. Well, it sounds dangerous. You see pericarditis, oh yeah, pain. Well, no, he has pain with inspiration. This is unexpected. He doesn't tell me that he's in cardiac tamponade. That is the problem I'm worried about. That will become a shock problem because it's going to push the heart. You hear muffled heart sound, JVD, the hypotension. Yes, he never told me the patient is in cardiac tamponade because this is a heart pericarditis, is the inflammation of the pericardium that will compress the heart. The heart cannot push. So you have muffled heart sound, JVD, hypotension, that's tamponade. That's a B-sharp moment. No, this is just pain with inspiration. I'm not worried about it. I'm not choosing you. You're not losing your life and limb. The client complained of worst headache of my life. Yes, this phrase, I know you know, is subarachnoid hemorrhage. Patient is dying, bleeding into his head. I need to see you. A client with suprapubic pain with transurethral retroprostatectomy, that is TEP, removing a portion of the prostate through the urethra. They usually get suprapubic pain after the procedure. It's the spasm that is unexpected. He's not losing his life. So this is what we left with. Now, I also put this, I just want to trick you guys a little bit, get you guys thinking. There's some you got to intervene, there's some you got to see first, and some you have to question. SATA form. A client with TB reporting vision change after study and ethambutol. TB, what's buzzwords? TB, vision, and ethambutol. Put it together. Does it make sense? Yes. TB patient, they put them on ethambutol One of the side effects of inhibitor is vision changes. This is not good. You got to let them see a doctor. That's why these people, we schedule them for ophthalmology appointment before they start developing intervention. So you got to intervene. So I need to intervene with this one. A client with bronchitis and a SAT of 92. He is COPD patient. His SAT is 92. It's not normal to me. But does he say anything? Shortness of breath. Okay. Is he in any sepsis, infection? Is he having airway issue, respiratory breathing, shortness of breath? Don't use the diagnosis as your bench line when you answer this question. Look at the whole totality, put everything together. This, and then you have to be sharp about it after that. This is not an airway. Bronchitis, yes, I know it affects his breathing, but his SAT is 92. There's nothing in the statement that's telling me he's having breathing issue. I'm not seeing you. A client with asthma on metoprolol for hypertension. A bunch of buzzwords. Asthma, metoprolol, buzzword. You know, asthma patient is not supposed to take beta blocker. But then I'm tricking you. What kind of beta blocker they cannot take? Non-selective beta blocker, NSB. Selective beta blocker is fine. And what are the selective beta blocker? BAM. That's called BAM. Bisoprostol, atenolol, and metoprolol. This is okay. It's taking metoprolol. Don't worry about it. Just be sharp. It's not a be sharp moment. If he's taking propanolol, yes. Anything that doesn't involve a BAM, I'm not worried about it. A client with AFib on heparin drip with a platelet of that, 10,000, 100,000. Do the connection. AFib, heparin, that's your buzzwords. You rewrite, everything is there. Therefore, heparin, if it's less than 150,000, that's a problem. This patient has a drop in heparin, that's heparin-induced thrombocytopenia. Is going to have what? Thrombosis. This thrombosis become what? A PE. And this PE is what? A breathing problem. You see how they can trick you? We're talking about heparin, but now we're talking about breathing. Yeah. Heparin decrease the platelet, 100,000 is below 150,000. Patient is going to have clots. Clots will go to the lung, have PE. PE is a B-sharp moment. Therefore, I need to intervene right away. A client with active TB on isoniazid prescribed with statin for cholesterol. Buzzwords: TB, isoniazid, and statin. Ask yourself, all TB medications affect your liver. A good statement you should remember. An individual dose medication has their specific side effect, but all of them affect the liver. If you affect the liver, it causes a little bit of cirrhosis or liver function will increase. Statin is another medication affect the liver. So you can't have two. You're causing too much injury to the liver. I need to intervene. A client with clots in the Foley bag 4 days after TEP. So after transurethral prostatectomy, 3 days, they can up to 3 days, they can have clot in it. If there's clot after 3 days, that means they're bleeding. This clot is what? Bleeding. This bleeding is what? Shock. This shock is a B-sharp moment. Therefore, intervene, see first, do something about it. Okay, another question. First intervene question. Same thing. A 60-year-old client with AFib and a heart rate of 60 after metoprolol. A bunch of words. AFib, heart rate, this. Do you see a B-sharp moment? There's no shock. There's no change in mental status. There's no clot, nothing like that. His heart rate is 60. What did you do to the patient? You give them metoprolol. That's what he did. He dropped his heart rate. That's an expected finding. I got to be sharp. No way. A 60-year-old client with MAP of 55 after liver biopsy. A good one day. What is your MAP? MAP is what? It has to be at least 65. And what does the MAP come from? Systolic blood pressure and diastolic blood pressure. They all come from that. If any of them is low, expect your MAP to be low. That's the way. I don't want to do the too much calculation, the formula. No. If any of them is low, systolic, diastolic, any of them is low, your MAP is going to be decrease. It's the mean arterial pressure. So it's the mean calculated in certain way based on certain pressures. And therefore the mean is too low. That means this patient is bleeding. That is bleeding. They're not going to tell you once again. Liver biopsy with the MAP of 55. They're not going to tell you that this patient is bleeding. If you're bleeding, you are in shock. I told you liver and kidney biopsies are vascular organs. If they're going to give you a question about liver biopsy or kidney biopsy, it's going to be like that. Either signs of bleeding or wrong position. So I need to see this patient. 10-year-old client with excessive clearing of the throat after tonsillectomy. Tonsil is where it's located. There's a lot of blood vessels there. Whenever they remove the tonsil, number one complication you're looking for is bleeding. So you tell the mother, breathing precaution, no contact sports for 14 days. If the kid is clearing their throat, let me know they're bleeding because they're swallowing, trying to get rid of it. If they're swallowing too much, they're bleeding. So this, you see these symptoms, you will not see them hypotensive, but these are early signs. Swallowing too much, trying to clear their throat, yeah, bleeding. If they involve in contact sports less than 14 days, they will bleed. So this patient is bleeding and therefore shock moment on the B sharp. 18-year-old client with mononucleosis and football game 12 days after diagnosis. The same thing. Mononucleosis is an infection, that viral infection that affect some of the glands in your salivary glands. And then the symptoms that you get, what your spleen get bigger. Spleen get bigger and your liver get bigger. Why? They're full of blood. They can rupture. So splenic rupture or liver rupture for mostly spleen will rupture. That's number one, because it's full of blood if you have mononucleosis. Because of that, no contact sports for 2 weeks, 14 days. This guy is playing soccer, football, 12 days. No, bad. It's going to bleed. I need to intervene. A 9-month-old client with severe audible congestion, cough, and excessive mucus. A bunch of words. They are a bunch of words. Break it down. 9-month-old. Okay. He has a severe audible congestion. Okay. Fine. He's coughing, excessive mucus. There's nothing telling you he's in respiratory distress, irritability, striding, drooling, and no buzzwords in the B sharp. All he says is, okay, cough, fine. Mucus, fine. Congestion, fine. There's never put the stridor. So this patient is fine. This bronchiolitis, RSV infection is fine. 45-year-old with left pneumothorax, small intermittent bubbling in the water cell. This is also worrisome, but guess what? It's not. Patient who has pneumothorax should have some air leak, small air leak as expected until the lung is expanded. That's why you put the chest tube in. Therefore, if you see small intermittent bubbling in the water cell chamber, yeah, the air leak will go away and then the patient will be fine. So that's where you check for air leak, water seal area. But if they already have pneumothorax, you expect some air leak there, which will resolve. This is not worrisome. I have to be sharp. Okay, so we have 2, 3, 4. It's getting hot, right, guys? Number 9. Same thing. The more we do it, you get used to it. Who do you see first? or they can change it. What is your intervention? I usually use the same phrase, but it doesn't matter. A client with the back pain and abdominal bruit. Okay, here is the patient. He has a bruit here near the belly button and he has back pain. What does that tell you? This abdominal aortic aneurysm. If you hear a bruit in the belly, it's always AAA. That's fine, but now they have a back pain. That's bleeding. The bruit is okay, but they're bleeding now. If you hear the bruit, we got to work up on it and let them see the doctor so that they can prevent him from bleeding. But now he has back pain. That's bleeding. And bleeding is shock. That's B-sharp movement. I'm seeing you. A client with right heart failure and a CVP of 18. What is CVP? Central venous pressure. That means the pressure in your central venous system is high. How would you know on physical exams? You see JVD. JVD, that means what? Right heart failure. That's a sign of right heart failure. CVP of 18. There's nothing they told me. The normal is abnormal. CVP has to be 2 to 8. 18 is too high. But the patient is not in any distress. They've not given me any information. Don't fall for it. It's a sign of heart failure. It's the diagnosis of right heart failure. I'm not seeing you. A client with rigid board-like abdomen 1 day after colon resection. This is sepsis. That's the key word. Rigid board-like abdomen. That's peritonitis. So sepsis is B-sharp movement. Board-like abdomen. Pay attention. A client with myasthenia gravis and difficulty in swallowing at night. That's a problem. You know these people, they need acetylcholine to function, okay? You give them acetylcholine. In the morning, they usually get weak. And then, no, they're stronger during the morning, so you let them take their medication during the morning. But during the end of the day, they get weaker. He has difficulty in swallowing at night. Okay, this is an expected finding because they're supposed to get weak at night. In the morning, they get stronger. But if this is happening in the morning, then you worry about it. They have to be stronger during the day, in the morning. And as the day go by, they get weaker. And therefore, at night, that is telling me this patient need more medication at night because it's an expected finding. His medication is not helping them get through it. It's a little bit confusing, but it's straightforward. They're usually stronger during the day and weaker during the night. So whatever you want to do, let them do it during the day. Whatever symptoms they have at night is an expected finding as they get weaker and get fatigued. So you let them take their medication in the morning, you let them do everything in the morning. So we may have to give the medication more, but I don't need to see the patient first. It's unexpected. You may need intervention to give them more medication so that it can last longer. Client with bronchitis and irritability. There's a buzzword here. Irritability is a sign of hypoxia, which is restlessness. Another way of saying restlessness. Restlessness is a B-sharp movement. That's airway issue. I see you. A client, cystic fibrosis and blood thin sputum. Connect them together. Cystic fibrosis, what do? A lot of thick sputum. And they have to cough violently to do that. Therefore, you expect a little bit of blood in them. That's fine. I never said they are having distress or anything like that. So this patient is fine. Number 10. We're almost done. A client with diabetes with blood sugar of 60 and confusion. Okay. So we have a confusion patient. His sugar is low, B-sharp movement. Therefore, this is my priority. Okay. Confusion, sugar is low, it's a B-sharp. I'm taking it right now. Then we have to look at the rest. Cellulitis of the leg and confusion. Another B-sharp movement. Is cellulitis and he has confusion. That means he has sepsis and confusion. Okay, B-sharp, another B-sharp. I intentionally said this for you guys to think. A client with sodium of 120 and confusion. Oh, okay. So hyponatremia will put the patient in seizure confusion. Another B sharp. A client with the femur fracture and confusion on admission. Confusion, B sharp. But look at the femur fracture. This has an airway also associated with it. This one, I need to put it. This has neurological associated with it. This one has sepsis associated with it. This has hypoglycemia. So they all a B sharp moment, priority, but they have other things. Femur fracture and confusion. This is fat embolism. When you hear fracture, confusion, petechia on the abdominal wall or chest, that's fat embolism. Therefore, this guy is an airway, but he's also confused. They both have P. A client with restlessness and a confusion after IV removal. Restlessness, B sharp moment. Confusion, B sharp moment. Priority. And therefore, this is as a catheter emboli going into the distance. So that's another airway problem. A client with excessive cough, confusion after ACE inhibitor. Cough, confusion, ACE inhibitor. What is number one problem with ACE inhibitor? Cough. When they're coughing, probably they're developing angioedema, which is another airway problem. So you see, we have a bunch of stuff here. So we have to see who do you see first. It's a SATA question. I forget to put the SATA there, but so we have a bunch of SATA, and so all of them you got to do something about it. So this, I intentionally said this. This one you got to see first. This you got to see. This you got to see. Good, you got to see. So we have like 3 airways, neuro problem, and then hypoglycemia and that. So all of them you have to see first. So it's a funny one. I put it there, but it illustrates a lot of important things I was trying to say. Like you have to evaluate them, put them into the B sharp, and then be able to recognize the keywords that this patient is not safe. So all of them are not safe. Yeah, some people have sepsis, some people, and then confused. So I need to see them. That's my favorite question for that one. Now we have the triage scenario. Who do you transport first to the trauma bay? Okay, and I told you look for what? Green, no, red and black. I'm not looking at anybody in between. Red and black. A client with fixed dilated pupil and brain matter exposed. Is fixed pupil, I mean, that patient is not surviving. So this is black. A client with multiple superficial laceration of the body is not black, it's not red. I don't care what color is there. I don't even going to even assign anything to him. Multiple laceration doesn't mean anything. They're not telling me he's bleeding. All you're looking for is shock, chest trauma, airway, and unstable wound. That's red. A client with 80% of total body surface, this patient is not surviving, is black. A client with no pulse and unresponsive, this black is not going to survive. A client with sucking chest wound, yes, I will assign something. This is red. Those are the 2 I need. A client with traumatic amputation and clot and the cloth saturated with blood, that is red. It's bleeding. Cloth saturated with blood, that means he has bled, he has hemorrhage. So it's in shock. It's part of my red. A client with audible stridor and bruising over the neck. Yes, stridor is an airway. So that's red. So this person need to be, this person need to be, this person need to be. All the rest, no. So just focus on the black and red. The other ones, don't even assign them. And then this is the delegation question. Okay, that's the last one. We just delegating. You have team, we have a RN, we have UPA, and an LPN. So RN eat, they rest MMR most, and then you know what the UAP does. Basically, anything that doesn't involve that. Vitals of patient admitted 48 hours. Who is going to do this? When they give you a 3 people, don't assign something the other one will do to the other person. So UAP job can be done by LPN. LPN job can be done by UAP. RN cannot job cannot be done by LPN. So don't get confused. When they give you 3 of them, you just assign whoever will do. Unless there's only one RN and RN, it will do all the job. So this has to be done by UAP. Change stomach bag. I know RN can do that, but this is the job for LPN. So don't confuse. It can change stomach bag. Change tube feed bag. Yes, LPN. MMR most. Check the other ones. Watch patient eat. I'm just watching the patient eat. I'm not doing anything. UAP job. Assist client to the bathroom. I'm just assisting them to the bathroom. UAP. Perform discharge summary education. This is RN job. Education. So RN. Listen to the long sounds after albuterol. Look at it carefully. I give the patient albuterol. I'm listening to the long sounds. What am I doing? Assessment. Who does assessment is RN. Initial vitals before blood transfusion. Who usually do blood check vitals before anything? This is blood transfusion. The UAP can do that. But after you start the transfusion within 50 minutes, RN has to do it. After 15 minutes, RN can delegate to the UAP or LPN, whoever, if the patient is stable. If the patient is not stable, the RN will do that. The reason why RN check blood and vitals within 15 minutes is because that's when blood transfusion reaction occur within 15 minutes. It's going to have transfusion reaction occur within 50 minutes. So that's why you have to give it to the RN to do it. After 15 minutes, patient is stable, everything is good, they can delegate to any other body. So this is the end of it. As you can see, prioritization is tricky, but it's doable. The B sharp make you stay focused and help you find the right patient that you need to worry about. Basically, as things in it that these symptoms are very worrisome, that you have to look at them twice. You got to look at them twice and say this patient is not stable. Like I say, it's a toolbox made up of versatile tools. You go in and pick up that tool and fix a problem. And therefore, I hope you learned something out of it. Good luck. And then thank you for continuing with the series. Keep charging as always. And I will see you later. Bye.